Hello, this is Dr. Lynn McPherson. I'm a professor at the University of Maryland School of Pharmacy, and I'm delighted to be with you in this educational journey. I'm accompanied by two of my colleagues who I will let introduce themselves.
Hello, my name is Dr. Nicole Brandt. I'm also a professor in geriatric pharmacotherapy here at the University of Maryland School of Pharmacy.
Hi, I'm Diana Stewart. I'm a clinical instructor at the University School of Maryland and a palliative care pharmacist.
All right, so let's jump in. This is a multi-module course on best practices in taking care of patients with an advanced illness. This is Module 1, Part 1, on principles of palliative care. So let's jump in. So these are the objectives for this program. First, at the end of both parts of Module 1, you'll be able to define and differentiate between palliative care and hospice care. Then you'll be able to determine if the goals of care need to be established within a patient case scenario, and most importantly, list 3 potential goals of care for end-of-life care. So when we look at the leading causes of death in the United States, as you can see, there are several to choose from here. Probably the lead contenders are heart disease and cancer. They are about equal. I think heart disease still has a bit of a lead over cancer, but they're pretty much neck and neck. So others are chronic lower respiratory infections, accidents or unintentional injuries, stroke, which is cerebrovascular disease, Alzheimer's, dementia, and there are other dementias, of course. Diabetes is a huge influence, and usually we don't see diabetes written on a death certificate as the cause of death, but certainly it is an enormous contributing factor. Influenza, pneumonia, kidney disease, and suicide are some other examples. So what about the burden of chronic illness? How much of a burden is this? Well, we know that really it's extremely prevalent. So if you look at older adults, at least 92% have at least one chronic disease. And you can read as well as I can, but clearly about 3/4 have 2 or more, at least half have 3 or more, and 1 in 5 have 5 or more chronic diseases. So you can imagine the burden this puts on patients and their families and their caregivers in taking care of all these chronic disorders. And these chronic diseases often are associated with long periods of decline and disability. When we look at trajectories of illness, for example, if you were hit by a car and it was a fatal event, you would be teapotting along at a pretty high functioning level until the time the car hit you, and then boom, that was your period of decline all in one swoop. But on the other hand, when we look at older adults, when they have all these chronic diseases, often we see this very slow decline, maybe with some ebb and flow where they have acute exacerbations and then they recover to some degree, but often it can be a very lengthy decline. Where do people die in the United States? Hospice, about 42%. Hospice, but with less than 3 days stay, is almost 10%. And that actually is a very large problem. So you will learn in this slide presentation that people can be referred to hospice when 2 physicians independently certify that they believe that the patient's disease continues along the expected trajectory that they would pass away within 6 months. So we have this 6-month window, yet 10% of the patients referred to hospice die in 3 days or less. So this is kind of hospice crisis management, and certainly does not the best use of hospice care. Nursing home stay in the last 90 days, 45%. 70% were hospitalized in the previous 90 days before death. That's certainly a statistic we would like to reduce. And even more onerous is intensive care unit stay in the past month is almost 1/3 of people. I don't know about you, but I would rather not die in the intensive care unit hooked up to 14 different machines. So what is palliative care? This is the formal definition from the World Health Organization. Let's read it together. An approach that improves the quality of life of patients and families facing the problems associated with life-threatening illness through the prevention of relief and suffering. This is from the World Health Organization. So some important points here is the unit of care is patients and families. And even though we could provide palliative care for you if you fell off your bicycle and scraped your knee, generally speaking, we're talking about advanced illness. So I talked on the slide about cancer or heart disease or Alzheimer's disease. These are the causes of death, and usually we're looking at taking care of the pain and the symptom and the psychological issues for the patient and the family as they traverse through that period of their life. Quality of life, as you know, is very important. It's not all about the quantity, it's also the quality. And this is very patient specific. What works for me may not work for you. But when we look at the quadrants of quality of life, what comprises it? Certainly physical well-being is an important part. Are you free of pain? Are you free of nausea, constipation? Psychological well-being. We see an awful lot of anxiety and depression and delirium, insomnia, social well-being, relationships with others, and spiritual well-being. So certainly we can look at all four quadrants of quality of life, and we try to maximize these as an important part of palliative care. Let's look at a case study. I love case studies, and my colleagues, feel free to jump in here at any point. We have poor Ms. Smith. She's an 82-year-old female with a past medical history of type 2 diabetes, heart failure, dementia, and chronic low back pain. Her social history, she's been married for 52 years. Wow, that she deserves a gold star for that. But her husband did pass away about 3 years ago. She has 2 adult children and 5 grandchildren. Unfortunately, she's become much more forgetful over the last 6 months. She's even stopped attending services at her local church because she lost her car in the parking lot. She has been hospitalized 3 times in the last 4 months for fluid overload or buildup secondary to heart failure. Her children are very concerned that she is not taking her medications properly and is no longer able to live alone safely. So, what do you think, Dr. Brandt? Got some situation here, don't we? Got some issues going on?
Quite a few, and imagine that. Sounds like she's got a lot of comorbidities, just like you talked about, Dr. McPherson.
That's right. So let's take a look here. Which aspects of well-being for Ms. Smith are being impacted on her quality of life? Is it the physical domain, psychological, social, spiritual, or could it be all of the above? Why don't you take a moment and think about it and jot down your answer. Well, look at that. It is all of the above. Are you surprised about that, Dr. Stewart?
Not at all. And I find that when we talk to patients about changes in their medical condition, it's also important to ask about changes in their home life or their routine, because these will often lead you to find out other issues that are going on. Particularly, the example of her no longer being able to attend church is something that can be very distressing to a lot of patients.
All right, so what are some of the principles of palliative care? I think these are all laudable goals. We want to provide relief of physical pain or discomfort and other distressing symptoms. We want to affirm life and dying as a normal part of the process. When we talk about hospice and palliative care, the goal is never to artificially extend someone's life, nor to end it prematurely. It's to affirm life and dying as normal, and importantly, to enhance the quality of life. So it's not hastening or postponing death. Integrating psychological and spiritual care. Often I see patients where the psychological and the spiritual aspects are far more concerning to the patient and the family than the physical aspects. Offer support to that whole unit of care, the patients and the family. And another important aspect is it takes a village to do this. It's not just the physician, it's not just the pharmacist or the nurse or the social worker. The care is provided by a team. And I always like to say that we're a transdisciplinary team, meaning everybody on the team is pretty knowledgeable about a significant portion of everyone else's position and what they bring to the whole team environment. And as I said, we're all rowing in the same direction to enhance the patient and the family's quality of life. And it's not just as people are very, very close to the end. The provision of palliative care is applicable much earlier in the disease process if the patient has a potentially life-threatening illness. So a good example of that is cancer. When someone is diagnosed with cancer, I believe they should be provided with palliative care right out of the gate. Sometimes it can be harder with other chronic diseases to pinpoint when it's appropriate to introduce palliative care, but I'm kind of on board with falling off the bike and scraping your knee, so maybe that's a good place to start. And palliative care certainly, of course, can be provided along with, concurrently, therapies that are intended to prolong the life. So we can still try to cure your cancer while we're treating your pain, for example. What are some of the misconceptions? Often patients or families feel like if I take palliative care or hospice care, I can't continue to get my chemotherapy, and that's just not true, particularly with palliative care. It's a little not as much in keeping with hospice care, but certainly with palliative care. Also, some people think palliative care means we're giving up hope. We never, never, never give up hope. We may hope for different things. We may not hope for a cure any longer, but we hope to find peace. We hope to be at peace in mind, body, and soul, free from pain and suffering. Is palliative care the same as hospice? Well, that's a yes and no answer to that. Both hospice and palliative care strive to take care of the patient and the family and enhance the quality of life in all four of those quadrants. But hospice is more of a governmentally regulated situation where it's, again, as I said, more prescriptive, people within 6 months of dying. Another misconception is it's only for cancer or people with an equally poor prognosis. But in fact, all those diseases that I showed you earlier that can lead to death are eligible for the administration of palliative care. And it absolutely does not hasten death. So these are some of the common misconceptions, and I think education is critically important. Would you agree with that, Dr. Brandt?
Absolutely. I think there is a lot of misconceptions, and families get confused between the difference between palliative care and hospice care and eligibility, which I think you're going to talk on.
Absolutely.
And I find when we go into the room to introduce ourselves as members of the palliative care teams, one of the first things that we have to do is reassure the family that we are not there to prevent them from seeking medical treatment, and we are not there as the dying squad. We're really just there to help them with their symptoms and improve their quality of life.
Excellent points. Okay, so what are some of the benefits of palliative care? I think we've alluded to most of these. To provide relief from symptoms that are troubling, such as pain or nausea or constipation or difficulty breathing. Addressing those psychosocial issues, which it could be financial. We still run into men who are terminally ill, and their biggest concern is, my wife has never balanced the checkbook in her life. So this could be something the social worker sits down with the wife and says, let's talk about your finances. Assist with setting goals, realistic goals, goals that are attainable in the time that the patient has. Support medical decision making, and this can be very difficult. Often patients want to give up curative therapies such as chemotherapy, and in fact may be a little pressured by family members or even some members of the healthcare team. So supporting the patient in making these decisions. And important also is supporting the family, which is our whole unit of care along with the patient. So, I've already spoken quite a bit about hospice, so let's talk about it officially here. Hospice is a Medicare benefit, and of course other insurance companies have modeled the Medicare benefit, and it has many similarities with palliative care. We are providing quality care for patients with a terminal illness, and just like palliative care, our focus is on caring, not necessarily curing, although palliative care cure may still be an option, but with hospice, definitely the focus is 100% on caring. Where do we provide hospice care? People tend to think that hospice is a place. Hospice can be provided in many places. The main three are shown here. It can be the person's residence, so it could be their own home, which is about 42%. It could be a long-term care or nursing home facility or a residential facility. And there are hospice programs that have their own inpatient facility, which could be part of a hospital, it could be part of a long-term care facility, or it could be a standalone building where patients are admitted just like to a hospital. Or we can provide hospice in a regular old acute care hospital. It could be in a unit where all those beds are together, or it could be what we call scatter beds. Such a hospital may say, we're going to dedicate 5 beds for hospice care, and they could be anywhere in the hospital. So hospice is a philosophy of care, not as much a place, although it may be a place. As I said earlier, hospice eligibility, 2 physicians independently determine the patient has 6 months or less to live if the terminal illness runs its expected course. So the physician would certify the patient is appropriate for admission to hospice, and then we reassess to assure the patient is still appropriate for hospice care. We initially recertify the patient at 3 months and again at 3 months. And what happens if the patient is still doing well and still alive at 6 months? Well, of course, we don't kick them to the curb. We keep the patient on service if it's still appropriate for the patient to be receiving hospice care. We just continue to evaluate it every 2-month interval if they're still appropriate. And again, care and comfort of the patient is the goal. Some of the principles of hospice: providing care for the patient and the family as a unit, as I've spoken of, focusing on, again, all 4 of those quadrants of quality of life: physical, psychological, social, and spiritual needs. Just like palliative care, hospice is provided by an interdisciplinary team. We have physicians, nurses, pharmacists, social workers, chaplains. We have bereavement volunteers, volunteers who visit with the patient, therapists. We even have people who are volunteers on our team, such as dentists or lawyers, who help patients at this time in their life. We provide education and support for the patient, the family, and the caregivers. So I love this quote, good care at the end of life. All of us, no matter what our age, gender, class, nationality, religious tradition or not, hope to die well, in reasonable comfort, ripe in years, compos mentis, surrounded by our loved ones, at peace with ourselves and the world, feeling we have lived a good life and are prepared to return to our ancestors. You'll often see in the hospice and palliative care literature talking about a good death. What the heck is a good death? I think that's a very patient-specific thing. Dr. Brandt, what do you think about that? What's a good death for you? Probably running a marathon, knowing you.
I think as you've articulated the principles of making sure you're making me comfortable and the most important things around me still being provided. So,
And Dr. Stewart, what do you think?
I think a good death means feeling at peace with your life and having the people that you love around you.
I always like to say that if I don't die before my to-do list is all crossed off, I'll live forever. So what are some of the limitations to medical care? First, do no harm. I think when people have an advanced illness, these can be really critical conversations to talk about the risks or the burdens as opposed to the benefits of all proposed therapies. Should we continue dialysis? Should we continue chemotherapy? At what point does chemotherapy cause more harm than good? It's more likely to cause side effects than to prolong your life. Or it may prolong your life by a couple of weeks, but at what cost? CPR. Everybody watches TV and thinks, oh my gosh, when you get CPR, when the doctors are done, they're going to jump back and you're going to jump off the stretcher and do a little dance. Well, it doesn't generally work that way. There are risks associated with resuscitation. We could break ribs on people who are elderly and frail and cachectic. What about surgery or invasive procedures? I'm a big believer in the WIFM game. What's in it for me? So I do think it's important to have those conversations. Even artificial hydration and nutrition. We don't certainly want anyone we love to starve to death. So families are very concerned about this, but there are risks associated with artificial hydration and nutrition. Dr. Brandt, you work with older folks. What are some of the risks there?
well, we often get worried about sometimes the talk and the discussion of putting in tubes and peg tubes and the increased risk of aspiration and other complications from the placement of the tubes. So, let alone if you're using IV hydration. So, but it can be very invasive, and that's a very important conversation to have, especially when you talk about decision making.
Absolutely.
Mm-hmm.
I mean, I don't want needles stuck in me when I'm circling the drain. How about you? I know I work mostly with hospice patients. Often they'll have a tube down their nose into their stomach, an enteral tube, and they have something like Ensure running. And if they're running too much of the Ensure, they start to retain fluid, and it's very difficult for them to breathe. So it's almost like they're drowning or in the artificial feeding. So important conversations to have. So Dr. Stewart, if you're close to the end, you want a bunch of lab monitoring?
I don't think I would really care what my potassium level is at the end of my life.
Absolutely. And then again, do you want to be rehospitalized? Goal setting is so important. This is very, very important. We often focus on medical decisions rather than the patient goals. So the patient's in charge. The patient and the family is the unit of care, and they are the captain of the ship. But they need information so that they can come up with the plan of care. So we want to make sure that we have the goals of care for the patient. Is comfort more important? Do you want to try additional therapies? Some people say, I want to try everything at all costs. Others are like, no, I just want to be comfortable. So whatever plan we come up with has to be consistent with the patient's values and wishes. So again, they need to be patient specific. Is it to pull out all the stops and go for a cure? Is it to be comfortable? Is it to do both? Are you trying to extend the patient's life? Improve or just maintain health? Achieve life goals? So many times we have hospice patients who hang on literally for the next big holiday. It's uncanny how many people pass away the day or two after Christmas or Easter or New Year's or their favorite grandchild's birthday or their granddaughter gets married or a high school graduation or a baby is born in the family. So people, I think, can hang on until they pass these important life events. And so important is supporting the family and the caregiver. So Dr. Brandt, tell me about the family and caregivers in caring for someone with end-stage Alzheimer's disease.
Oh, it's so important. We have so much literature showing by supporting the family, the caregiver unit, you can keep people as independent much longer, but there's so much stress, there's so much blame, and it's very challenging. So they need ongoing, constant support. And I always remember a patient who had I would say, is a good death at his home, surrounded by his family. They said, well, we always used to threaten him with not taking his medication, saying that Dr. Brandt's going to come and make sure you take those medications. So it's really important, because there's a lot of blame if they can't get the medications into their loved one. But I just find, as they see this long enduring neurodegenerative disease such as Alzheimer's disease really take their loved one away is really hard. And
It is.
a lot of grieving throughout.
But how
Yeah.
about the professional caregivers also, like in long-term care, the staff that work there, assisted living?
It's huge. We know that we have a rapid turnover, and having support. We've actually worked with our hospice team to actually do education, not just for the family caregivers, but the professional caregivers as well. I often tend to find, though, maybe an under recognition of that. So I think there's a lot more we can do professionally to bring that attention.
Absolutely. They're an important part of the team, and they grieve too when patients die.
Absolutely, and probably sometimes it's just as much as families, we have to remember.
Absolutely. So, establishing the goal of care may involve a legal document, an advance directive, a living will, a durable power of attorney, and importantly, in Maryland, the MOLST, and in other states, it would be called a POLST. So, you want to set up a family meeting. Again, this is a big team meeting here. The whole professional team, the family, the caregiver, the patient certainly can be a part of this meeting. The sooner the better, ideally at the time of diagnosis. And the purpose of this meeting is to provide that education Dr. Brandt was just talking about. Disease state education to the patient, the family, the caregivers. Talk about priorities in end-of-life care and developing a plan, and shape the future clinical care according to the patient's preferences and values. And often I find that the patient wants things that I personally would not choose to do. So how do you wrestle with that, Dr. Stewart?
I think you have to separate out what your own preferences are from what's best for the patient. Sometimes patients would prefer to undergo treatments that you, in your medical opinion, might not think are appropriate, but you need to come to some kind of agreement with patients and find some middle ground there.
And as pharmacists, we certainly see that with medications all the time, don't we?
Sure.
Good points. So, setting up the meeting, ask for permission to speak with the family or caregivers, find out if the patient would like to talk and when, and if there's information they would rather not know. That's an important question, is how much would you like to know about your disease process? Make sure all the key players are at the table. Be open and honest, but certainly to use compassion at all times. Respect the patient wishes if they don't want to talk. Make sure they understand that if they don't make their decisions known, the patient will get everything, such as CPR, mechanical ventilation. And what do you do, Dr. Brandt, if the conversation is not going well? What do you think?
You come back to it. I think there's an acceptance, and just as we're learning about their illness, learning about their prognosis, it might be overwhelming. So we have to take pause and come back to it. So I know we always like to put an agenda together, Dr. McPherson, that we're going to get through all of these items, but having the sensitivity and listening to where your patient is just struggling with some of these decisions. And we experienced this in team discussion yesterday when we talked about giving someone a diagnosis of moderate stage of dementia and talking about advanced decision making. He's like, wait, I just got this diagnosis. Let me absorb that, and then let's come back to that.
Absolutely.
So, important.
And I think another important thing is if you set the time for the meeting, say 2 o'clock in the afternoon, and the patient is physically uncomfortable, Dr. Stewart, what do you think? Do you just tell them to suck it up and be a little soldier, or what do you think?
That would be a very mean thing to do. I think if I noticed the patient was uncomfortable, I would certainly ask them if they were experiencing any pain. But make sure you get the nurse involved. Ask if there's a medication that we could give to make the patient more comfortable. And if they don't, that's definitely another area that you could address.
There you go. All right, so I think the way we word things is important. We certainly don't want to offend anyone or hurt their feelings. Phrases to avoid. There's nothing else we can do. That sounds like we're putting Fluffy down, doesn't it? This is the last or only option for you. Boy, talk about backing somebody into a corner. Asking a leading question like, would you like us to do everything? That's sort of like, have you stopped beating your wife yet? Of course you don't want to ask leading questions. Do you want quantity or quality of life? Boy, that's kind of a dichotomous question, isn't it? I'd like to have both, thank you very much, and a donut with chocolate on top. And to say to someone, we've decided to withdraw care, I think that's the ultimate throw somebody under a bus. So let's go back to our case of poor Ms. Smith. She returns to the ER 2 days after discharge for difficulty breathing and fluid buildup in her legs secondary to heart failure. Her doctor is concerned that she may require a breathing tube if her respiratory status worsens. When Ms. Smith hears this, she becomes tearful and asks the doctor, "Can't you just fix my heart?" So do you think Ms. Smith would benefit from discussing goals of care? What do you think, Dr. Stewart?
I think this would be an excellent time, and especially to get her family involved and find out what the patient's wishes are. The great thing about some of these situations, if you have these meetings early, you can hear from the patient themselves. One of my least favorite situations is when the patient is on a breathing tube and is no longer able to express their wishes, because that can be such a terrible burden for the family to feel like they're grappling with these decisions by themselves.
I agree. So the answer is yes, you would. So how would you approach a situation? Let's see if Dr. Brandt knows the answer. A, tell Ms. Smith that mechanical ventilation is a routine procedure, nothing to be worried about. We could do your nails while you're under. B, ask Ms. Smith if you could set up a meeting with herself, her doctor, and her family to discuss what has taken place during hospitalization. What do you think?
Oh, I don't know, Dr. McPherson. That's a really
It's a tough
one.
choice,
It's
I
really
know.
tough. I really think I'm going to go with B.
Option B.
But sometimes it's easier, right? It's easier just to say, hey, we can do this routine procedure, because it's sometimes more cumbersome on the healthcare team to set up these meetings, get everybody coordinated. But I'll tell you, from a quality of life and a quality of care perspective, B is much more rewarding. And I think we need to make sure we don't take the easy way out.
Okay, let's see if Dr. Brandt got it right. By golly, she did. Not only is she good looking, but she's a smart cookie too. All right, so this concludes part 1 of Module 1. I hope you've enjoyed it. I think we've laid the groundwork nicely for our entire course. I will see you in part 2.